Hello, everybody. Thank you for joining us today on this webinar, which is going to be about Introduction to Value-Based Medicine. My name is Dr. Avinash Jayaswal. I am the newly appointed Chief Medical Officer in the company. Very glad to have joined. I'll start out by introducing myself and then introducing the panelists. So a little bit about myself. I am a doctor with quite a bit of experience, both in inpatient as well as outpatient settings. I've worked as an ER physician and in surgery, as well as had some experience working in family practice as well. Hence, I understand the providers in the outpatient, as well as the constraints and challenges of inpatient settings. I joined as CMO to bring my experience to the job and to contribute in what is now the new norm of value-based medicine. Our Chief Operating Officer, Stan Gutkin, is amongst us today. He is going to just watch me present as I go ahead and introduce our speakers. So Dr. Baran Erdik, who spoke already last week, and he will be speaking again. So he's our advisor on regulatory compliance and practice transformation with focus on value-based care. He's an expert on policy and health administration and is actively involved with compliance both at the state and federal levels. I'll also introduce Dr. Bherenji, who's advisor on risk stratification and clinical outcomes. She's double board certified in occupational and environmental, as well as preventive medicine, currently now moved to California, in the Los Angeles area, as opposed to Boston. I guess it's a good time to move before the winter. And Beverly Gibson, our advisor on medical documentation, billing, as well as revenue cycle management, vastly experienced with audit, risk mitigation, and medical record auditing. She has expertise in multiple medical specialties and knows all the three code sets, namely CPT, ICD-10, and HCPCS. So without further delay, let me introduce Dr. Erdik, who will start us off.
Hi guys, as Dr. Jayaswal introduced, I'm Dr. Baran Erdik, and then I've been CCMLed as the advisor for regulatory compliance and practice transformation, and with a particular focus on value-based healthcare. So we'll be discussing some key changes that have happened in the recent couple of years here. So most important is you may have heard some of these MACRA, MIPS, FFS, PCMH, and all these good abbreviations. So one caveat before I even go further is that there's just a lot of information here. And if you're not in tune with the regulatory environment, these abbreviations and whatnot, this will just be an overview, sort of getting your feet wet. So if you need or want to learn more and want to get your feet even wet and learn how to swim, then we will be posting further deep dive webinars on these topics, and then you can follow CCM Health on social media to get the dates for this. So with that, as you may all remember, what's been happening is that before 2010 and before Obamacare and before all of this, if you served a patient, if you'd seen a patient, then you billed for it. And what you billed, you got paid. So ultimately, this became up to the point that this wasn't really sustainable. The Congress had to come to the rescue. Every year, almost, the doctors had to beg for increases. And basically, you were billing a lot and you were getting paid somewhat, but there was nothing to show for it. If you want to look at OECD countries, ultimately, US was, and still to an extent, is spending the most with the least amount in return. So then the Congress wanted to act upon it. So ultimately, what happened was the Medicare Access and Chip Reauthorization Act of 2015, MACRA. So this replaced the 1997 Sustainable Growth Rate Formula to determine the Medicare reimbursement. And this was of note a bipartisan legislation, so there was support on both ends of the spectrum. And ultimately, this provided a new approach in Medicare reimbursement with a value and quality care focus. So basically, the Medicare's goal became not just to pay the physicians or the clinicians for rendering service, but to ultimately improve patient outcomes, enhance experience, increase APMs, which are advanced alternative payment models, promote program understanding, and then ensure operational excellence. So the main one, other than the APM, which we'll discuss at the end for a brief minute or two, is the MIPS system, which is going to be the focus on today's webinar from my part. So the MIPS is the merit-based incentive payment system. You may have heard of this. And what MIPS did ultimately was it combined three legacy programs. These are the PQRS, the Physician Quality Reporting System, the Value-Based Payment Modifier, and the Medicare EHR Incentives Program. So, of note, you may think, well, why should I worry about this? Because you're probably already in MIPS and you're probably already unaware that you're in MIPS. There is some exemptions if you're really low volume, like less than $90,000 a year or less than 200 patients. But then even if you're in those groups, you can still opt in. And if you furnish less than 200 covered services, you're exempt, but you can still opt in. Or if you're participating in an advanced alternative payment program, AAPM, or like a PCMH of sorts, then you can technically choose to opt in, but you don't have to. Of note, this year, there's also an easy opt-out because of the pandemic, but that's going to be gone come December 31st. So CMS essentially predicted 88% of providers will be in MIPS versus an APM, but that is being skewed right now, and we'll have some further data, but my guesstimate would be it'll be above 90%. So what is happening? What's the bottom line? The bottom line is you're in a program that you may or may not already know you're in, and you need to do well because there's a carrot or a stick. So if you're doing good, then you're going to be looking at possible 9% reimbursement. And there's also a 3 times potential in that with a modifier. So technically it can be up to 27%. Or if you're not doing good, you will be penalized 9%. So think about it this way. You will be billing $100, so you can either choose to get $91 off that 100, or you can choose to get $109 out of that 100. So the difference is staggering, especially the more services you render for Medicare patients. So CMS projected that the bigger fish were going to be okay. So the bigger the clinical entity, the bigger the group, the less affected they would have been. And the smaller they are, the more affected they would have been. This is also to an extent important because technically this MIPS is supposed to be a budget neutral program, meaning the money that CMS takes from the people that are being penalized goes to the people that are being actively incentivized, that are being given that bonus. So we as physicians are a competitive breed, right? We had to work hard to get in the medical school, residency spots, interviews, subspecialty, USMLE, whatever, you name it. So basically, CMS to an extent figured it out with laws and regulations and whatnot, that the best way for them to achieve what they were willing to achieve is to bet physicians against each other in a sense, because ultimately we'll discuss scoring and quality and all of that good stuff. But bottom line, this scoring depends on how other people are doing. So it's like a curve in your classroom. If one person gets 100, everyone else gets a 50, there won't be much of a curve grading. But if everyone gets 50, then there will be a good curve. So keep that in mind before we head into the next sections. So if we briefly look at what CMS thought would happen, is that for nephrology, for cardiology, they thought about 40% of the providers would be losers. And then the 50-60% would get that bonus. So then the question you got to ask is, which part of this equation do I want to be? Do I want to be losing money, even though I'm rendering the same service because I just don't check the boxes that I should be checking or CMS wants me to check? Or do I want to be on the other side and provide really high quality service, not just see the patient, but make sure that I'm checking the boxes that need to be checked and I'm providing the value-based quality added service that is expected of a physician in the year 2021 and future. So if we briefly look at what the MIPS score is about. You get scored on 4 different things: quality, cost, clinical improvement, and advancing care information. So if you see quality was really high at the beginning, slowly coming down, meanwhile cost is increasing. So of note, the most important one out of all of this is quality, because cost is automatically calculated by CMS and reported. Clinical improvement and advanced care information, to an extent, are things we have all been doing for the last 10 years with the advent of EHRs and stuff. And on the other side of the medallion, with clinical improvement and advancing care information, some of this is just attestation, meaning are we doing this or yes. But quality, we really got to work on it. There's things we can do, there's things we may be doing, but we can do better, and there's things we should definitely be doing. So ultimately, there's 209 measures you can choose from for quality. These change every year based on input from American Academy of Family Medicine and yada yada, all these specialty groups. And technically for specialties, there's specific specialty sets that should be the focus of your specialty. But do you have to obey them? Not necessarily. You can choose any one of these 209. So you will be expected to select 6 of these. And then at least one outcome here has to be high priority, meaning it has to be an outcome measure or a high priority measure. So you would get bonus points for these outcome mortality readmission measures or patient experience and then high priority. If you're a small practice, you get a small practice bonus, and then each measure would be submitted using electronic reporting, would also give you a 1 point bonus. So here are some specialty measure examples. So for example, if you are dealing with a lot of diabetes patients, you may wish to choose the first one, where CMS is basically looking at what % of your patient set has poorly controlled diabetes. So hemoglobin A1C, poor control over 9%. Or if you're dealing with lots of coronary artery disease, cardiologists, maybe are your patients on ticagrelor, or are they on beta blockers or whatnot? The caveat here is you may all be thinking, but okay, I prescribed this to the patient, they didn't take it. What am I supposed to do? Well, that's all the point of this, right? So that's all about chronic care management, and that's all the things that my colleague, Dr. Bherenji, will discuss. But at the end of the day, what CMS is trying to do is to ensure that the ball is not dropped, that there's continuity of care, and that the buck stops with the clinician, not with the prescription. So what are we gonna do? I mean, first, we need to maximize this, right? So we need to pick things that we can do good at. So we need to target measures with lower benchmarks so we can reach higher percentiles easily, because as I've stated before, we are actively being compared to the competition, to other providers that are similar to us. So if everyone is doing good with 99 percentile in one thing, then if we do 95, that's not good enough. But if everyone's about 70, 75%, that means if we get 80, then we're doing really good. So this also goes to say that we can't technically choose to use the specialty sets because they're probably going to be most relevant to us. And if we're a specialty, that means our competition will be other specialists in that set instead of just family care or primary care and sort of that. So for cost, this is similar to value modifier for those of us that'll remember it from the good old days. But ultimately, this is the total cost per capita for all attributed beneficiaries and Medicare spend per beneficiary clinician. So this also, to an extent, goes to quality, right? So if I'm managing diabetes well in my patient, that means that patient is unlikely to go to the ER in diabetic ketoacidosis, or unlikely to have an amputation, all that good stuff. So basically, with quality, you're also being incentivized to minimize the cost, because an ounce of prevention is worth a pound of cure. So CMS is trying to get you to ensure there's good chronic care management, good prevention, so that your costs will be in check. So you'll also get a good score from there. Of note, this is not a reporting requirement. CMS retrieves the cost data, and then telehealth is counted. So how about clinical practice improvements? 105 activities in 2021. The medium weight ones are 10, high ones are 20. I mean, you get up to 40 points and then basically you attest yes. So are you doing this? Yes, I am. Yes, I'm not. Of note here is that you need to ensure that you are actually attesting yes for things that you're doing, such as care coordination or beneficiary engagement or patient safety or whatever. And if you ever get an audit, you can have a paper trail showing that you've actually done these things, not just attested yes. So promoting interoperability, this is basically your EHR use to an extent. Are you e-prescribing? Are you using a health information exchange? Are you using certified EHR? So if you're doing all of this, then you're going to get a good score, and which is capped at 100 points. So these are just some of the examples for PI. I mean, if you're doing e-prescribing, if you're checking the drug monitoring program, and then you cap out, and once you cap out, you're golden. You cap out at 100 points. And if you're reporting one use case for each measure, then you get a 60 base points, basically. So how are people doing with this system? So at the end of the day, the mean and median scores are the latest data set available to us is 2019. I'm going to mention that in a second, and the limitations of the system, because you're being graded 2 years after the fact. But if you can notice, the mean score has gone down a little bit and the median score has gone down a lot. So that means that the people that are being graded, the clinicians and small practices, they are being cluttered in the middle. Instead of having a gap, they're being cluttered in the middle. So for small practice, you can say the same pattern. So that means, especially if you're a small to medium practice, you're going to have to work harder to get out of the bulk of the group. So you're going to have to be maybe 2, 3, 4 standard deviations ahead of the game to even have a shot at competing with the bigger fish in the pond. So for example, if we had a MIPS score of 57.48, that would actually be a negative adjustment. So it just depends on what the scoring is for that year. But at the end of the day, we need to be really sure that we are not just doing fine, we're doing really good. So we are getting the positive adjustments. We are getting that bonus money that we can get. So again, if you're engaged versus you're participated, you're going to be more likely to do well. And this has been becoming more and more so, because at the beginning, everyone was in the learning curve. Everyone was learning what was happening. But the more time started to pass, some people became really engaged and some people just checked out. So the question you got to ask yourself is, do I want to be actively engaged? Do I want to be chasing that bonus? Do I want to be doing chronic care management? Or am I just going to be in this program without even knowing I'm in this program and possibly facing those penalties? So as I said, our two main issues is that there's no absolute standards, right? I mean, CMS doesn't say, oh, 85% in this is good. CMS says you're being compared to other people. So if everyone does good, then good luck. So you need to be better. The other second issue is that we are being graded 2 years after the fact. So what you do this year will affect your payment in 2023. And then this becomes problematic for small, mid-sized practices. I mean, if I'm Kaiser Permanente, I mean, I'm the big fish, right? I'm sure I can hire 10 staff members and 20 statisticians, figure out what I'm good in, report those, and be done with it. But if you are a smaller fish, you don't have that luxury. So you're becoming to the point where you don't necessarily have the time to spend 20 hours a day looking at your data, figuring out what it is. So you need to figure out if it's good for you or if it would work for you to get some sort of outside assistance. So ultimately, the crux of the matter is that on average, an elderly patient has 6 diagnosable disorders. Doesn't mean you're aware of all of this. It just means they have them and you can diagnose them. So chronic care management covers at least 33 measures under quality. So most of these are high priority, meaning in order to do MIPS, you need to do chronic care management. And for chronic care management, CMS will also reimburse since 2015 if this is physician-led and if you're spending 20 minutes a month of clinical staff time. So at the end of the day, if you're also doing good chronic care management, you will be doing clinical improvements, cost resource use, and advanced care information. So that's one thing. Chronic care management is the key to MIPS and will help you achieve not just good scoring and quality, but in all other 3 domains as well. So at the end of the day, if you're doing that, then you're gold. But what is chronic care management? I'll mention it in a second, and then I'll give the mic to my colleague, Dr. Bherenji. So basically, in order to be able to build this chronic care management, I mean, you need to provide some sort of access to care management services. So the CMS doesn't want patients just randomly showing up at the ER. They want clinician to be able to handle the chronic disease of the patient and to an extent prevent exacerbations. So yes, a patient with COPD will have acute exacerbations due to viral infection or whatever. But if they're managed well from a baseline perspective, for most, they should be able to handle it at home. Or if they need some sort of antibiotics, azithromycin, whatever, then probably you can just call it into the pharmacy without them going to the urgent care. Or the same thing with patients with diabetes. If they are just constantly up and down, hyperglycemic, hypoglycemic, hypo, then there's just no good control. And what CMS is trying to achieve is that to have the clinician drum up a plan that is particular for that patient, and there's some sort of continuation of that plan, just not when the patient is being seen, but outside of the clinical setting in their home and so on and so forth. And that also enables the coordination and transition between the care settings. So basically, you're not just saying, oh, let's just get this patient to an endocrinologist. You're actively referring that patient. You're seeing if the patient went to the endocrinologist and so on. So we mentioned APMs. What is an APM? So these are alternative payment methods. They're not subject to MIPS, and they receive a lump sum 5% bonus, and they will receive a higher fee schedule onwards. There's a lot depending on what specialty you are. So, but at the end of the day, if you are primary care or internal medicine, the most likely one you may have heard of is a PCMH. So PCMH is a patient-centered medical home. And basically, it's what we mentioned with chronic care management as an accreditation. So basically, it's person-centered, coordinated, comprehensive, accessible care that is committed to quality and safety. So it's that when you prescribe insulin to a patient, but the patient suddenly is homeless, you contact a social worker. You arrange for that patient to keep having that insulin no matter what, so that there is some sort of follow-up and you're not just letting the patient develop consequences from not taking the insulin. So it has to bring a lot of things together, and it's ultimately a one-stop shop from a patient perspective. So if the patient is an elderly patient and falls down and can't really cook anymore because they can't stand, then they may qualify for a Medicaid waiver, comp waiver, so they get home health care. But then as the primary care physician or the patient-centered medical home, you will be helping patients arrange that instead of just letting them sort it out, so that the chronic care management is done and possible aggravations of their different diseases are prevented. Ultimately, this boils down to triple aim. You may have heard of this, which has been the driving force in US healthcare since early 2010s, that improving healthcare and outcomes while reducing per capita cost. And with 5 principles that is physician-led. Remember, physician is the captain of the boat. You can't just delegate these duties to a secretary and expect them to draw up everything and do it. It needs to be led by a physician. It needs to be whole person oriented. So their social circumstances, familial circumstances, and so on and so forth. Integrated and coordinated care. So if you send them to the endocrinologist, you need to ensure that there's appropriate follow-up. Focused on quality and safety. I mean, are we providing what we need to be to prevent bad outcomes, and prioritizing access? So meaning if a patient with diabetes suddenly calls your office and says, oh, my blood sugar is 300, you can't really be expected to see them next week, right? You need to arrange your schedule so they have priority access. So how do we become a PCMH? You need to get accredited. There's 4 current recognized programs by CMS. They all sort of want the same thing. Most common one you may have heard of may be the NCQA or the Joint Commission. I mean, at the end of the day, they're all sort of looking at the same thing, right? So patient access and then quality care management and so on and so forth. So as we said, from a primary care physician perspective, ultimately this PCMH stuff with chronic care management as well, it's going to be your relationship based. So like you need to collaborate with your other personnel. That includes maybe you have PAs, maybe you have NPs, whomever they may be. Needs to be built around the patient needs. So maybe a patient works 40 hours a week. Their only available time for appointments is 3 p.m. at Friday. So that needs to be built around the patient. Or at the end of the day, it also needs to be physician dependent, so needs clinical efficiency and expertise. So physician has to say, well, I get that Miss Jackson is calling the office 20 times a day, but she doesn't have anything clinically. She's just lonely and maybe depressed because her husband died. So we need a social worker out there, sort of. So from a MIPS perspective, PCMH will increase your payments because you're more than likely, if you choose to get on with MIPS while doing PCMH, not just take the 5% lump sum, but choose to actually do the full MIPS, because you're going to be getting the full credit for improvement activities and you'll do well in other quality measures because you're actually providing quality care. You're actually doing what CMS wants you to do. You're doing chronic care management, following up with the patient, giving them access and all that good stuff. Same thing with resource use, because if you're preventing the bad outcomes in these patients, then they are not going to the ER, so they are not using resources. So they're handled internally in your clinic. So from a CMS perspective, they're cheap patients and you're doing good. As we said, I mean, if you as a PCMH or an APM, you can choose to get that 5% lump sum bonus. That's probably mainly designed because there's ongoing costs to being a PCMH, like a PCMH manager or clinical lead. But again, you can choose to enroll in MIPS as a PCMH and get even that 9% bonus. And basically, if you can show that you're accredited, you can also have increased billing opportunities with Medicaid and private insurances, showing them that you actually do provide higher quality care than your competition and you're accredited for doing it. So, I mean, ultimately, at the end of the day, you're already being scored from a CMS MIPS perspective, and you're either going to get the carrot or the stick. So you may already have been penalized, or you may have maybe gotten a bonus. So time is now to take action. That time is of crucial matter because we only have a couple more months left till the end of this year. And to remember, we will be scored 2 years after the fact. And with that, I give the mic to my colleague, Dr. Bherenji, who will go through some use case scenarios and try to put this more in a clinical perspective instead of just like an overview from a more regulatory perspective.
Thank you, Dr. Erdik. Hello, everybody. My name is Manny Bherenji, double board certified occupational medicine as well as preventive medicine physician. I've worked in a variety of different clinical settings over my 8 years since graduating from residency. I have worked actively as a clinician, and I'm currently advising Fortune 500 companies when it comes to their COVID-19 surveillance programming and employee wellness operations. Next slide, please. So I know it's a Wednesday afternoon, evening for a lot of you, and we want to be able to provide some high quality information to really guide you in your practices. And Dr. Erdik did a fantastic job really kind of giving the regulatory overview. But when it comes to the nuts and bolts of a clinical operation, it's really important to have everything set up in terms of your practice and your operational model. You guys know what you do best, taking care of patients, but it's important to be able to have folks working on the back end to make sure that all the other services are being taken care of, making sure that your patients are getting their medications on time, making sure that the specialty appointments are being taken care of, and making sure that the patients make those appointments. It does take a village, and really focusing on the chronic care management piece is essential. Next slide, please. So as an individual, as a group practice, you guys can do a lot. You have your clinical director, you have your operations team. You're able to take care of patients as they're coming in, making sure that they're getting their labs, making sure that they're getting their needs met. You're fulfilling those benchmarks as much as you possibly can. But there are current constraints to, what you as an individual, what you as a practice can do to really check off all those boxes when it comes to the current regulatory requirements. So that's where it's important to, again, have a team having the chronic care management piece really set in stone, if you will, where you can have outreach to the patients on a regular basis, making sure that you're taking care of all those medical conditions like diabetes, like the blood pressure issues. These are things that as clinicians, we know how to treat, but it's important to be able to continuously assess how folks are doing. Clearly, things can happen in real time. I mean, you can only do so much in that 15-minute encounter you have every 3 months or so. So being able to incorporate some of these chronic care management principles can really help you do what you do best. Next slide. So Dr. Erdik really went into this, so I'm not going to take too much time on this, but really understanding that chronic care management is a critical component of the delivery care model. And ensuring that you're able to address all these metrics really helps your patients be their best selves, essentially. Next slide. Next slide. So this is really focused on education today. We really want to make sure that you understand chronic care management, incorporating some new technologies, and being able to create that personalized experience that patients really are craving. So if you look at the graphic on the right-hand side, you can see the spokes of the wheel. So we know chronic care management when it comes to diabetes, we got to get those serial hemoglobin A1Cs. We got to make sure that patients are getting their medications on time, making sure that they're getting their insulin, making sure they're getting their test strips to be able to continuously monitor their sugar levels. So it's important to be able to have everything bundled, so that way there's really no worry about whether a patient got his medications refilled for that month or whether they have enough test strips. Really, it's a matter of kind of keeping everything, making everything easy for the clinician, so that way they can do what they need to do to monitor for any changes, if there are any other medical conditions that come up that could potentially interfere with the respective disease state. Clearly, injuries, accidents, things happen. So we really want the clinicians to take care of the patient, and incorporating some of these chronic care management principles and technologies and tools to help you in what you do. Next slide. So technology is such an important piece of this, really being able to incorporate wearable devices, being able to communicate with patients utilizing telehealth. There are so many things out there in the marketplace, but really focusing on what's high yield for you and your practice in delivering that care and making sure that patients are actively engaged in the process. It's really important to be able to incorporate all of these elements together. Next slide, please. Education for patients. I can't say this enough. We, as clinicians, have an obligation to continuously educate our patients with new information, about a disease or a condition. Medications are coming out. People really are looking to us for guidance, and we want to be able to provide them that guidance. So you want to use your time with your patient. I know many of you have panels of up to 1,500, possibly more, possibly less, but you want to be able to spend that time that you have with them, really educating them on their respective diseases. And many of these folks are older, they have multiple medical conditions. It's a tough act to follow, to be able to really understand what these folks are going through on a day-to-day basis. You're looking at their lab work, you're looking at trends, you're looking at the specialty notes. I mean, you're trying to kind of bring all these elements together. So being able to have software that can really kind of help you navigate a patient's course over the previous 3 to 6 months, looking at serial measurements of blood pressure, for instance, or glucose levels, that really helps you gain a better picture of what a patient is experiencing. Next slide. Guidance for physicians, clinicians, this is so important. We always need to continuously update ourselves, not only in terms of advances in medicine, in disease states, medications. This is just part of how we operate as clinicians. Things are always evolving and changing. So being able to understand how such technologies, especially in the chronic care, population health space, can help you and your respective colleagues enhance what you offer and potentially even expand on your services to really achieve those outcomes for your patients. That's really something that is high yield for you and really for everyone involved. Next slide. So really focusing on the technological bit, I think that's really important. Having specialized wireless remote monitoring devices that your patients can connect to easily. I know a lot of folks have issues getting broadband service. A lot of times there could be issues with reception. So having ways for patients to being able to use these devices where it is simple to use, easy to understand, really helps the patient engage in his or her own health. So really trying to provide that to each and every patient can really kind of help individual clinicians who are trying to monitor what's happening with their respective patient, but also on a population level, having all that data is really informative because it can guide your practice model. So incorporating the equipment, the software elements, all of this does come together to really create a robust chronic care management program. Next slide. So we're just gonna kind of highlight a case here. So we have Miss Maria. She's a 74-year-old female. She lives by herself, but she does have family nearby. She does have a few medical conditions. We want to make sure that she's doing okay. She has 4 diseases. She has multiple medications, as you can see there, 22. She has 20 healthcare providers. It's hard to kind of keep up with Miss Maria because she has a lot going on. And, being able to have a place where you can consolidate all the specialty consultations, all the respective lab work, all the medication, and the respective reconciliations, kind of being able to look at trends over time on one platform can really help Miss Maria continue to lead her best life. We want to make sure that she has a high quality life. So it's important to be able to incorporate all of these elements into a platform that is able to deliver for Miss Maria, able to deliver for you, the clinician, as well as deliver for the practice as a whole. Next slide. So benefits of using a specialized chronic care management platform. There are a lot of benefits. As you can see here on the left-hand slide, being able to incorporate such a systematic approach can lead to cost savings. As you can see here for diabetes patients, by utilizing these elements, you can save up to $1,600 plus per year, per patient per year. And that speaks volumes. I mean, that does add up. A lot of folks who have diabetes can benefit not only in terms of getting higher quality care as a result of incorporating such a chronic care management platform into the practice, but it really kind of provides additional value to everyone involved, all the stakeholders, the patients, the clinicians, the payers. I mean, everyone really benefits from this. So it's really important to be able to understand these principles, to being able to spend more time with your patients, incorporating new technologies and platforms that can reach out to your patients. It really does make a difference. Next slide. So again, focusing on the technological aspects here, it's so important to be able to incorporate these new population health management tools, so that way you can continuously assess your patients in real time, be able to reach out to them in case they need additional assistance, and then being able to monitor them through their life course. You can see here that improving the quality of life for the patient is of utmost importance in this chronic care management platform. And looking at, net promoter scores, I mean, that clearly is an indicator that the industry does refer to when looking at how respective groups are doing. You always want to achieve that higher net promoter score. So really focusing at the end of the day on ways that you can deliver that high quality care, capture all those metrics that you need to capture, and ensuring that you're able to create a viable, sustainable practice. It's something that I think all of us want to strive for. Next slide. So again, looking at the diabetes example, clearly incorporating these new technological tools with the software enhancements can really yield results, as you can see here, up to 21% reduction in insulin costs. Clearly, we want to reduce the number of hospitalizations as much as possible. So being able to identify those factors further upstream, that way you can prevent a patient from going to the emergency room, God forbid. We're always trying to look for ways to ensure that these patients are getting their needs met, and having these systems in place really helps with that. Next slide, please. So this is a really busy slide. I don't expect anyone to read this, but really what I want you to focus on is how complicated things can get for a patient with diabetes. Taking into account all the comorbidities, we always want to be looking for ways where we can reduce those medical care gaps. And if you look at those red boxes in this protocol slide, those are all the medical care gaps that clearly impact the patient, especially those diabetic patients. Really, the goal is to close those care gaps as much as possible. And that's why having a cohesive platform, a population health platform, can really help reduce some of those care gaps. Next slide. We always look at benchmarks. We always want to see compared to other commercial and governmental entities, how this specific chronic care management tool really compares. And you can see in the green columns, both on the right and left sides, that at least compared to the benchmarks for commercial, the benchmarks for Medicaid, Medicare, these new platform for chronic care disease management really does achieve the outcomes that we're looking for, especially when it comes to hemoglobin A1C and diabetes management. Next slide. So thank you guys so much for your attention. I'm going to go ahead and introduce Ms. Beverly Gibson. She is the advisor for medical documentation, coding, billing, and revenue cycle management. Thank you.
So you have heard quite a bit today from two very well qualified subject matter experts. They gave us a jam-packed presentation, so I wouldn't be surprised if you have questions. This is the time for you to pose them to our experts. You could either raise your hand and voice your question orally, or if you prefer, you can put your question in the chat box.
So that brings us to the end of our presentations today. Thank you very much, all of you, for joining us. And
Dr. Jayaswal?
Yes.
I'm sorry, I don't think Beverly got through her part just yet. I think she was just at the question level.
Okay, sure.
Yeah.
Yeah, and I did want to make sure everybody got their questions answered. I will tell you that you'll have another chance to ask questions because we are going to be inviting each of you to a one-on-one session, and that would be a great time to ask any questions that you might think of in the meantime, and especially those that are specific to your practice. I want to assure you that that session is not going to be a sales pitch. The point of the session is to answer your questions, to see how the CCM health model might specifically benefit your practice and your patients, and then to see if we're a good fit for you and you're a good fit for us. So we're more than willing to invest an hour of our time, make sure that your objectives match ours and that we would collaborate well together. If you've got an hour of your time that you can invest, respond to the email that we'll be sending out. We'll schedule a time that suits your schedule. And in any case, we want to thank you for your time today, and we look forward to continuing the conversation very soon.
Thank you, everybody.
Bye-bye.
Thank you. Bye-bye.
Oh, yeah, it looks like somebody has a last question. Confirm that the components, which components should be present in the care plan? There are a lot of components that need to be in that. So we could go ahead and answer that in this email to you.
If you want me to just read it,
Absolutely, yeah, sure. Go ahead, Dr.
I mean,
Bherenji.
it's basically everything a health provider has to know, right? So like you're gonna have your medical history, condition list, medical records, whatever has come towards you, medication, allergies, providers, all that good stuff. So yes, there's a lot of checkboxes there, but at the end of the day, you gotta ask yourself, is this something that every health provider, like if someone that has not seen this patient needs to know, then the answer is probably a yes.
And what I'd like to do, and I do appreciate the questions because I think they're useful for everybody, but what I'd like to do is when I send you that information on place of service, I I think that I can get a sample care plan out to you so that you can see what that looks like.
So I just want to wrap up a few more things to make sure that everybody's clear. All the things that you guys are asking are very, very valid, and that's actually exactly what we do. So we enable you by giving you technology and by providing you the human resources, so it is possible for independent providers or larger groups to deploy the systems within their practice. The goal is to reduce hospitalizations, reduce readmissions, improve clinical outcomes, and obviously it needs to make business sense, so the practices will see exponential revenue growth. But again, the focus has to be quality healthcare, and it has to be patient-driven. So independently, we'll be meeting with you guys, and we'll conduct an assessment, just like Beverly mentioned, and we'll see if the partnership makes sense. Well, we hope we answered your questions. We hope that you had a good time, and we'll see you later. Thank you.